Okay, good morning, good afternoon, good evening po sa lahat. Saan man po kayong panig ng mundo naroon. Welcome po to our 181st episode now in our webinar series called Health Updates. And thank you for being part of our credible online community. And to all those who have just discovered us for today, welcome po. At exciting po ang pag-uusapan natin sa araw na ito. We will be looking into the intricacies po ng mga bagong and latest diabetes medications. Maybe looking into the pharmacological mechanisms, molecular targets, clinical outcomes. Ano pa po ba yung pwede nating mas matutunan in this evolving pharmacotherapeutic landscape? Ang ating pong esteemed panel of speakers po, they will share their insights and expertise on the latest developments on diabetes medications. Ano po ba yung mga novel approaches and promise to revolutionize diabetes management? So sit tight. At sana po marami pong magtanong ng kaya lang alam ko marami po kayong mga katanungan about diabetes medication po. I'm Dr. Raymond Francis Sarmiento, Director of National Telehealth Center, National Institutes of Health, University of the Philippines, Manila. Always a pleasure to be with all of you during our regular Friday. And for this Friday, as you would know, Dr. Dion Sakdalan, the PGH Coordinator for Training, will be co-hosting this program with me. Dr. Dion?
Hello, good afternoon, everyone. Good afternoon, Dr. Raymond. Welcome again to all our participants here in the live broadcast of Zoom webinar and to all those watching live via live streaming on TVUP YouTube channel, as well as those in UP System Facebook page, the TVUP Facebook page as well. And of course, all those watching across the globe. We also welcome our speakers and the panelists for this afternoon's webinar. Both are respectable clinicians in their field of practice in endocrinology, and they're also alumni of the UP College of Medicine and the Philippine General Hospital. So, as Raymond has mentioned, we've reformatted our Friday webinars, and now we've called it Health Updates, and we have done some tweaking and reformatting, but we are, of course, maintaining the same high-quality discussion and leveling it up to take a closer look at the existing and emerging health problems in our country and the rest of the world. So, because we made it a little shorter, we want to really go into the heart of the discussion. So our program will also be a little bit shorter. But before we go to that presentation, maybe Dr. Raymond would like to introduce our person on the street video.
Thank you, Dr. Dion, and thank you so much. For those who have already put in your questions po, maraming salamat. Putting in questions dito po sa Q&A and also in the comment section po sa ating YouTube and in our Facebook. For those who are joining us for today for the very first time, meron po tayong tinatawag na person on the street video. It's something that we often start with just to take the pulse of the common folks on the street kung ano po yung intindi po nila about the webinar topic. And for our questions that we post for today, ang mga katanungan po natin, kayo po ba or may kakilala po kayong na-diagnose ng diabetes? Bakit sa tingin ninyo dapat gamutin ang diabetes? Ano ang inyong ginagamit na gamot para sa diabetes at meron po bang mga side effects ito? Please watch this.
5 years ago, ako ay naging na-diagnose ako as diabetes.
Yes, my husband is diabetic and I am also diabetic.
My father had type 1 diabetes. He was diagnosed around, I think he was around 21. And it's hereditary yung sa kanya. So,
well, ang diabetes, wala kang nararamdaman eh. Pero sometimes, ang nararamdaman ko lang, yung pagka-hypoglycemia ko at saka kailangan gamutin mo kasi internal organ ang sinisira niya.
Kasi kung mapababayaan, there will be a lot of complications that come from it. Because when you have diabetes, your blood sugar is very high and that is not good for the cells of our body.
Hindi mo alam nasira na pala yung mga ugat-ugat mo, yung mata mo, yung puso mo, mga kidney mo ay sisirain niya. Kaya ang prepare ko para matagal-tagal pa bago masira yung aking internal organ.
I wouldn't call it a disease, I'll just call it a sickness, no? I think it's one of the hardest sicknesses to maintain, especially given the diet. It's very important to have better, newer, modern ways of medicating this condition.
Okay pa naman ako dahil na susundan ko yung mga medisina na binigay ng doktor sa akin, especially yung binigay sa akin na ginagamit ko na once a week yung Ozempic, tapos yung umaga is Darjan's Duo at saka Metformin. Yan ang mga gamot na ginagamit ko. As of today,
Oh, there's a lot. I use metformin. I drink metformin. My husband drinks sitagliptin, Jardians, and yeah, that's it.
My dad, he used Lantus and Epidra, the vial version. Kasi I know, alam ko there's a pen version, but my dad would use the vial version and extracted himself with needles, no?
okay pa naman ako, malakas ako, at saka ang napipil ko lang ay mahirap pag ginutom ako kasi magbababa yung aking magka-hypoglycemia ako. Yun ang kinakatakutan ko. Pero sa lahat, okay pa naman ako.
If you don't drink your medicine, you'll have high blood sugar. While if you drink your medicine, your blood sugar goes down. The complications usually if you don't get the correct dosage.
Yes, actually, it could, if not taken as prescribed, it can really affect yung mood ng tao or whoever is taking the medication. My dad kasi he wouldn't take it as prescribed yun. So there were side effects na he'd have seizures, things like that, and
Hypoglycemia is one side effect. If you don't get the real dosage, then you might have hypoglycemia. That's why when you are on diabetic medication, you have to monitor your blood sugar.
in my own personal opinion, I really wish that there was more transparency and clarity in terms of the usage of Lantus and Epidra. I just hope in the future that it'll be easier for people with diabetes, because I know how hard it is for the patients and also for the families of the patients.
Okay, thank you so much, TVUP. Always very enlightening po, no? Just eye-opening kung ano po yung naiintindihan po nila, especially kung ano po yung kanilang needs patungkol po sa mga bagong diabetes medications. Before we start with our webinar proper lang po, we just wanted to make sure that everyone is aware na yung pong mga certificates of attendance will be given only to those who have watched at least 50% of the webinar duration. And if you feel you should have received but did not, please email us at stopcovidets@up.edu.ph. Yung pong mga webinars po, webinars 1 to 180 na submit na po namin, send na po namin yung mga certificates na yon. So please check po. Yung iba po kasi lumalabas daw po siya sa may spam folder po nila. For webinar today, we'll be having a standard panel discussion format, and after our speakers have presented, then we move on to our Q&A session po. So we'll get our webinar underway and Dr. Dion will introduce our main speaker po.
Okay, thank you, Dr. Raymond. Bigatin po ang ating mga speakers today. Later on, you'll realize they are both leaders in their institutions of practice, but siguro po, maintindihan po natin kung bakit, because they're both from the College of Medicine. Our main speaker went abroad. She went to Cleveland Clinic to do her IM residency, and then eventually to Chicago at the University of Illinois for her specialization in endocrinology. Now, she's the chief of the section of endocrinology, diabetes, and metabolism in Asian Hospital and Medical Center. Our main speaker, please welcome Dr. Joy Arabel Fontanilla. Good afternoon, ma'am.
Magandang tanghali po sa inyo lahat. Thank you, Dion, for the very kind introduction. Pwede ko na i-share yung slides ko.
Yes, ma'am. Go ahead po.
Please, go ahead, ma'am.
Maraming salamat po para sa, for the invitation. I'm so glad to be here, and I would really like to greet everybody. Ang ganda nung person on the street interview ninyo. And we'll cover some of those medications that they talked about. So today we'll talk about the new diabetes medications on the block. So ano po yung mga bagong gamot na nandito na po sa ating bansa. Pero hindi po natin pag-uusapan lahat-lahat po ng gamot. Ang dami pong gamot ng diabetes. Medyo ifo-focus lang po natin yung discussion. So we'll talk about a little bit on the pathophysiology of type 2 diabetes. Ano po ba yung mga problema kung bakit tumataas yung blood sugar, paano nagkakaroon ng diabetes sa mga taong na-diagnose with diabetes. How do we manage diabetes? Get an overview of how we treat diabetes pharmacologically. And some of the newer medications, although hindi na po siya masyadong bago, they've been around for more than 2 decades, like the GLP-1 agonists, DPP-4 inhibitors, and the newer ones, the SGLT2 inhibitors. And a little blurb on how to reduce diabetes complications. So umpisan po muna natin, talk about what is the pathophysiology of type 2 diabetes. This is the natural history of patients with diabetes. And nakakalungkot po kasi even before the diagnosis of diabetes, we see that patients may already have complications. So at the start, we do have adequate incretin function. Ang incretins po, yun po yung mga hormones natin sa intestines. Papaliwanag ko po in more detail later. But that does go down as the disease progresses. Yung beta cell function, our pancreas is not able to produce enough insulin as time goes on. In fact, if you're diagnosed with diabetes for 10 years or more, the likelihood of you needing insulin after 10 years is very high. So diabetes starts off with insulin resistance. You may have increased insulin secretion at the start. In fact, pwede nga mataas yung insulin levels natin sa umpisa, and then that goes down with time. But insulin resistance persists throughout the course of the disease. And if you look at the blood glucoses, the first abnormality that you see in people with diabetes is actually the postprandial blood glucose. Yung blood sugars after meals are the ones that go up much earlier than the fasting glucose. So if we're screening for diabetes just with the fasting glucose, we're missing a lot of people with diabetes. And like I said earlier, the complications can already set in even before the diagnosis of diabetes. So we have to diagnose this as soon as we can, as early as we can.
Let's go over a few terms.
So for
These are the measures of
sorry.
fasting.
So for the levels of glucose, try to remember kung ano yung normal. Kasi po may mga laboratory sa labas na hindi po updated yung normal ranges nila. So for fasting glucose, it should be less than 100 milligrams per deciliter. If you do an oral glucose tolerance test, wherein you take 75 grams of glucose and check the blood sugar 2 hours after, it should be less than 140 milligrams per deciliter. And if you check the HbA1c or A1c, it should be less than 5.7%. And anything above that is already elevated. Ngayon, kung na-diagnose po kayo ng pre-diabetes or borderline diabetes, or may pasyente po kayo na-diagnose with pre-diabetes, huwag niyo po sabihin okay lang sila. Kasi po, kailangan po talaga ma-monitor yung mga taong yon at maiwasan yung complications. Sila po ay dapat ma-instruct tungkol sa paano gamutin or paano alagaan ang sarili para hindi na ho tumaas yung blood sugar at lumala yung mga komplikasyon kung meron silang komplikasyon. Kaya importante po is we need to screen our patients with diagnosed diabetes. For those with type 2 diabetes, at the very point of diagnosis, they should be screened for eye disease, kidney disease, and nerve disease, neuropathy. So retinopathy, nephropathy, neuropathy. So at the start, patients with diabetes should be seen by the ophthalmologist so that they can do a comprehensive exam. For the kidneys, we need to do an easy test. It's a urine microalbumin to creatinine ratio test. It's just a spot urine, and we check their creatinine to calculate for the estimated GFR. But I would be remiss if I did not talk about the other aspects of treating diabetes. We really need to do a more holistic approach to treat our patients with diabetes. Hindi lang po blood sugar ang minamanage pag merong diabetes. So, at the very base of the treatment, lifestyle modification, importante pa rin ho talaga ang pagkain ng tama, pagkain ng mga masustansyang pagkain, katulad ng mga prutas at gulay, bawasan po yung mga processed foods, and diabetes education po, very important. So maganda po kung sa mga lugar ninyo, meron po kayong mga diabetes educators or diabetes education clinics. Malaking tulong po sila para maturuan yung mga pasyente paano pangalagaan ang kanilang mga sarili. So blood glucose management is important, blood pressure management, lipids, yung mga cholesterol po, kailangan po makontrol din po yan. And considering po mga gamot or medicines with cardiovascular and kidney benefits. Ngayon, for the people with obesity, we should also think about weight management in these patients. When patients have overweight or obesity, we have to try to help them to lose weight as much as we can, because losing weight can also help address these other problems. Ngayon, bago po natin pag-usapan yung mga gamot, let me just give you a brief history of the current diabetes medications we have. So 1921, we've discovered insulin. And 1955, the sulfonylureas. All right. So in 1921, may insulin na po tayo. And since then, marami na pong developments with insulin. Marami na pong mga iba't ibang klaseng insulin. Each one an improvement on the version before. Yung unang mga gamot natin na tableta, sulfonylureas, pero yun nga po ang kanilang side effect. You can have weight gain, you can have hypoglycemia, mabagsak po yung blood sugar. And in 1959, so senior citizen na po, si metformin, meron po tayong gamot. Bakit po may bulaklak dito? Metformin was actually derived from the French lilac. Ayan, so herbal po siya. And metformin has been around for so long, pero mabisang gamot pa rin ho siya. And then matagal bago ho tayo nagkaroon ng mga iba't ibang gamot. So since the 1990s, we've had these medications called the TZDs or thiazolidinediones. Yung unang gamot po na lumabas ay triglyceride. Then we also have your meglitinides na kamukha rin po ng mga sulfonylurea. Ang ginagawa po nila ay tinataas po yung pag-release po ng insulin sa katawan. Kaya ang side effect din po niyan is hypoglycemia. Lumabas din po yung mga AGIs or alpha-glucosidase inhibitors katulad ng acarbose. Ang acarbose po, ang ginagawa po nito, dinidelay po yung pag-absorb ng mga carbohydrates. Kaya po hindi masyadong magsa-spike yung blood sugar pagkatapos nating uminom nito. And then back in 2005, ayan na, lumabas na po yung mga mas makabagong mga gamot. So we had the short-acting GLP-1 receptor agonist called exenatide. Injection po yan. Twice a day po na injection. And then the year after, we had our DPP-4 inhibitors. Paliwanag ko po in more detail mamaya. Ang unang DPP-4 inhibitor na lumabas po is sitagliptin. All right. And in 2010, we had our longer-acting GLP-1 receptor agonist. Nandiyan na po yung liraglutide. And then after that, years after, lumabas na rin po yung mga once-a-week injections. Katulad ng semaglutide, dulaglutide. And in 2013, we have our new oral medications called the SGLT2 inhibitors. Yung active ingredient po is derived from the bark of the apple tree. All right. So going to the pathophysiology of diabetes, marami pong mga problema sa mga taong may diabetes. So in the past, we talked about the terrible triumvirate. Ano po yung mga defects in people with diabetes? So the terrible triumvirate includes decreased insulin secretion, increased hepatic glucose production, and decreased glucose uptake or insulin resistance in the periphery in your muscles. And we have medications that can target each of these different defects. Now, for the ominous, and then years after, in 2009, Dr. Ralph DeFronzo, one of the pillars in diabetes care, described the ominous octet. All right, so maliban po dun sa tatlong yun, the other defects include increased glucagon secretion from our out of control alpha cells. We have decreased incretin effect, and I will talk about that a little bit more later. Increased lipolysis from our fat cells. We have maladaptive kidneys that have increased glucose reabsorption, and neurotransmitter dysfunctions, or nerves are also involved, particularly the central nervous system. And we have all these different medications that can target these various defects. And then more recently, more defects were found, and we now call this the egregious 11. So nagdagdag po dun sa 8, yung tatlo, abnormal microbiota. So yung mga bacteria po sa gut ng mga tao may diabetes, kakaiba po sila. And they contribute to the high blood sugar. You have increased rate of glucose absorption. And we have immune dysregulation or inflammation. And there are medications and ways by which we can address these other defects. But the final common denominator in the pathophysiology of diabetes really is the reduction in insulin secretion, which is why the blood glucose goes up. Ngayon, sa dami ng mga gamot for diabetes, how will we choose the diabetes medications? How do we personalize? How do we individualize treatment? So the American Diabetes Association recommends a person-centered shared decision-making approach. And kailangan po, tingnan nga natin yung pasyente holistically. We have to look at their comorbidities. So tingnan po natin if they have cardiovascular, renal comorbidities. Do they have congestive heart failure, or are they prone to congestive heart failure? Do they have problems with the kidneys? Meron na po ba silang protein sa urine nila? Mataas na po ba yung creatinine nila? We have to look at those, or are they at risk for having a cardiovascular event? So sino po ba yung mga high risk for cardiovascular events? Those who are 55 years old and above, yung mga mataas ang blood pressure, those with lipid abnormalities, those with chronic kidney disease or evidence of kidney disease, those who have enlarged hearts or left ventricular hypertrophy, etc. We have to look at the effectiveness of the medication. Will that medicine be effective in that particular patient? We have to look at hypoglycemia risk. Is the patient high risk for hypoglycemia? Kanina pinag-usapan ng person on the street na nagka-seizure siya because of hypoglycemia. There are patients who are not able to tell if they're getting hypoglycemic or if their blood glucose is going very, very low. Hindi nila nalalaman. Usually, dapat nalalaman natin kung bumabagsak yung blood sugar natin. Nagkakaroon ng palpitations, tremors, or pinagpapawisan ng malamig para malaman kung nagkakaroon na ng hypoglycemia. But there are some patients, especially those who have neuropathy, who do not have that ability to tell that they're getting hypoglycemic. And we have to look also at the medication and its impact on weight. Meron po mga gamot na nakakataas ng timbang, nakakataba. Meron po mga gamot na nakakabawas ng timbang. And of course, cost and access. Sa Pilipinas, very, very conscious din po tayo dun sa cost because most patients do pay for the medications out of pocket. And we need to look at the risk for adverse reactions. Ano po ba yung mga side effects ng mga gamot and the tolerability to these medications. And of course, nandyan po yung individual preference. So it's shared decision-making. Pinag-usapan po natin, in-explain po natin sa pasyente ano po ba yung mga posible na mga side effects ng mga gamot ito para mag-agree po tayo kung ano po yung mga gamot na iinumin ng mga pasyente. And because I showed you those many pathophysiologic defects, the recommendation po talaga is early combination therapy can be considered even at treatment initiation, to shorten the time to attainment of individualized treatment goals and hopefully to reduce the risk of complications. So usong-uso na po ngayon yung mga combination, kaya may maririnig kayong mga gamot na combined already with metformin. And usually combination po yan with metformin. Kasi nga po metformin, kahit napakatandang gamot na yan, mabisa-mabisa pa rin po at kasama pa rin po siya sa mga nire-recommenda na gamot para sa mga tao may diabetes. Okay, so ito po ang isang algorithm to lower blood glucose in patients with type 2 diabetes. This is freely downloadable. You can access it from the American Diabetes Association website. But basically, lahat po ng pasyente may diabetes, we should encourage healthy lifestyle behaviors, diet and exercise, encourage them to undergo diabetes self-management education and support. So if you have diabetes educators in your area or institution, please send them to those people who can help your patients. And of course, don't forget the social determinants of health, the cost of care, is the patient able to care for themselves, or do they have caregivers, and so on. And remember the goals of treatment, hindi lang po blood sugar. Nandyan po yung cardiorenal risk reduction for patients with diabetes. Look at them comprehensively to reduce the risk of having a heart attack, stroke, or whatever cardiovascular event. And the other goals of weight management, besides blood glucose reduction, should be taken into consideration. So in our patients with high risk for cardiovascular disease, there are certain medications that are preferred in those patients. Patients who are high risk of cardiovascular risk, like those who are 55 years and older, who have obesity, hypertension, who smoke, who have dyslipidemia or albuminuria, we are encouraged to prescribe GLP-1 receptor agonists and SGLT2 inhibitors. For those with heart failure, we are encouraged to prescribe SGLT2 inhibitors. And for those who have chronic kidney disease, the preferred medicines are your SGLT2 inhibitors. And if there are contraindications, then you go to the GLP-1 receptor agonist. And if you have none of these indications, definitely part of your medication should be metformin, and consider combination therapy. If your patients have very high glucoses, if their HbA1cs are 10 and above, if their blood glucoses are 300 and above, or if they have signs of hypercatabolism, weight loss, polydipsia, polyuria, polyphagia, uhaw na uhaw sila parate, bumabagsak yung timbang, then consider use of insulin already in those patients. No? Wag po tayo matakot sa insulin. Madali na po siyang maibigay ngayon. May mga insulin pens na na available. Pero sa ngayong hapon po or sa ngayong tanghali, pag-usapan na po natin yung mga mas makabagong mga gamot po muna. Pwede po natin pag-usapan yung insulin sa Q&A. Ito po another algorithm from the American Association of Clinical Endocrinologists, which looks similar to what the American Diabetes Association has proposed, looking at the complications present in your patients. Of course, lifestyle intervention is there, and independent of glycemic target and other diabetes therapies, if they have cardiovascular disease, GLP-1 receptor agonists or SGLT2 inhibitors are recommended. If they have heart failure, SGLT2 inhibitors. If they have stroke or TIA, GLP-1 receptor agonists or pioglitazone. Chronic kidney disease, consider SGLT2 inhibitors or GLP-1 receptor agonists. And if your patients have A1Cs of 7.5% and above, consider combination therapy already. If their A1C is 9 and above or 1.5% above their goal, then consider even 2 or 3 agents in those patients. Now, if they don't have any of these comorbidities, then consider these medications. Metformin should be one of the base medications. If your patient has overweight or obesity, these medications can all be given. Pero remember, if your patient has overweight or obesity and you give sulfonylureas, you can cause hypoglycemia and increase in weight. For hypoglycemia risk, definitely we give the medicines that don't increase the risk for hypoglycemia, like GLP-1 receptor agonists or your SGLT2 inhibitors, DPP-4 inhibitors, or TZDs. If access or cost is a big consideration, then the less expensive medications after metformin will be your sulfonylureas and your TZDs. And for those with severe hyperglycemia, and who have hypercatabolic symptoms like weight loss, polydipsia, polyuria, then your choice of medicine should include insulin or combinations of insulin and GLP-1 receptor agonists or a GLP-1 receptor agonist. Sige, isa-isahin po natin yung iba't ibang mga gamot. So metformin, matagal na po nating kaibigan yan. Alam po natin na mabisa siya. It does not cause hypoglycemia. It's weight neutral. In fact, in some patients, it might cause a little bit of weight loss. And it may have potential benefit against the major adverse cardiovascular events or MACE. And it's low cost, very cost effective. It's contraindicated, however, in our patients with a GFR of less than 30 mils per minute. And GI side effects, we have to watch out for that. So to reduce the risk of side effects, you have to titrate the dose slowly. Umpisan po natin sa 500 milligrams once a day. Then after a week, saka nyo po itaas by another 500 milligrams. You can also use extended release formulations or yung XR formulation, which has a lower chance of having these side effects. Or you can take it with food para mas mababa po yung chance ng GI upset. You have to remember, though, that especially if you've been on metformin for a long time or you've been on high doses for a long time, you may get B12 deficiency because it reduces absorption of your B12. Your pioglitazone or your thiazolidinediones or TZDs, they're very effective. Matandang gamot na rin po yan. They do not cause hypoglycemia and may have benefit against major adverse cardiovascular events. Another plus for the pioglitazone, you have benefits with non-alcoholic steatohepatitis or fatty liver. You don't need to dose adjust for kidneys, and it's also low cost. May mga generic na po yan. But side effects, pwede po magkaroon ng weight gain. You can increase the risk for heart failure because of fluid retention and increase the risk for bone fractures. Now we move on po to the newer medications that have come out the year 2005 onwards. So ito po yung mga gamot that target the incretins. So one of our major incretins is the GLP-1 or glucagon-like peptide 1. And when you give GLP-1 receptor agonists or when you increase levels of your GLP-1, GLP-1 targets multiple organs in our body. It can increase beta cell proliferation in the pancreas, reduce beta cell death, increase insulin secretion, and reduce glucagon secretion. Glucagon, alam po natin, counter-regulatory hormone natin yan na nakakataas ng blood sugar. It reduces hepatic glucose production. It slows down gastric emptying. Mas mabagal po yung pag-empty ng stomach, kaya mas mabilis po mabusog. It reduces appetite in the brain, and it reduces adiposity in the fat cells. Ngayon, yung incretins po natin, or yung GLP-1 and GIP, incretins, they came up with the word incretin because of the mistaken notion that intestines secrete insulin. But it's not the intestines that secrete insulin, it's actually the pancreas. But it's true that there are hormones in our intestines, in our gut, called GLP-1 and GIP, which increase the release of insulin in the pancreas. So when we eat, it stimulates our GI tract to produce our incretins, GLP-1 and GIP. However, GLP-1 and GIP have a very short half-life. Half-life is about 1 to 2 minutes. So medications are designed called the DPP-4 inhibitors to inhibit the enzyme that shortens or that degrades the enzyme, that degrades your GLP-1 and GIP. So if you give a DPP-4 inhibitor, your GIP and GLP-1 can last much longer. So ito po yung mga DPP-4 inhibitors, yung po nag-i-end sa gliptin. So yan, marami po yan. May vildagliptin, sitagliptin, linagliptin. How do they act? They inhibit the enzyme, yung DPP-4, which is responsible for degrading your GLP-1. And these are tablets. All right. They are intermediate in efficacy, so not as efficacious as your metformin, but effective nevertheless. So what are the pros? Hindi po siya nakakause ng hypoglycemia. They are weight neutral, they don't cause weight gain, and they're proven to be safe cardiovascularly. However, one of them, yung saxagliptin, may have the potential for increasing heart failure risk. And another plus for this medication, they can be used in kidney disease. So any stage of kidney disease, kahit nakadialysis na, pwede pong uminom ng DPP-4 inhibitor. What are the drawbacks? The cost. So the cost, hindi po siya kasing mura ng metformin. There might be a risk of pancreatitis, and it can rarely cause increase in joint pains. And in some patients, they have a rare autoimmune problem that causes bullous pemphigoid. We just have to remember, when we have kidney disease, you may need to dose adjust depending on the gliptin that you're on. You don't have to dose adjust for these gliptins, linagliptin, teneligliptin, and gemcitabine. Now, ito na po yung mga siguro naririnig nyo sa balita. Yan po yung pinag-usapan ng person on the street natin, yung mga Ozempic, Trulicity, etc. So yung GLP-1 agonist, nandiyan po yung dulaglutide, lixisenatide, semaglutide. Ngayon, siningit ko po yung tirzepatide. So strictly, hindi po siya GLP-1 agonist lang. It's a dual agonist. It's an agonist for both the GLP-1 and GIP. Wala po ho siya sa Pilipinas, but it's coming out within the year. And how do the GLP-1 agonists act? Basically, they activate the GLP-1 receptor, enhance insulin secretion, reduce glucagon, and slow down gastric emptying. It also reduces the appetite. Kaya po marami pong nagtitake nito para pumayat. Pero gamot po talaga siya for diabetes. Ayan. Meron po siyang mga studies wherein binibigay po siya for weight loss. Sa abroad, approved po sila for weight loss. Sa Pilipinas, ang approved lang po natin for weight loss and diabetes is liraglutide. Okay. They're very, very effective and they're injectable. So GLP-1 agonists are very effective for reducing blood glucose. Wala po siyang hypoglycemia. You have weight loss with them, and the benefits, you can have benefits for the heart, for the kidneys, and for fatty liver. Ano po ba yung drawbacks? So in rats, they have been found to increase thyroid C-cell tumors. Ngayon, rats kasi po, they have a lot of C-cells in their thyroid. In humans, we don't have those receptors that are stimulated by GLP-1. Pero syempre, we have to watch out for that. Kaya po, in patients with medullary thyroid cancer or MEN, we don't prescribe this medication. What are the side effects? Usually gastrointestinal. So, nausea, vomiting, in some cases, ileus intestinal blockage. Kasi bumabagal nga po yung galaw ng bituka. There's a question it might cause or increase risk for pancreatitis and increase risk for gallbladder disease or cholecystitis. So we need to modify the diet to mitigate the GI side effects. Kailangan po kumain na mabagal, kailangan pong nguyain na maigi yung pagkain, huwag pong hihiga agad pagkatapos kumain. People have to stand or stay upright for at least 2 hours after eating para hindi po magkaroon or para ma-minimize po yung side effects ng gamot na to. And finally, we come to the SGLT2 inhibitors. So these are the medicines that end with the suffix gliflozin. Ano po ba ang mechanism of action? They inhibit the SGLT2 receptor in the proximal nephrons. Basically, they block the absorption of glucose in the kidneys and therefore cause glucosuria. You lose approximately 200 to 300 calories of sugar in the urine. And that's why this medicine can also cause weight loss. It is intermediate to high in efficacy, so they're effective, and they're given orally. It does not cause hypoglycemia. Yun po yung one of the benefits. Weight loss as well, and a lot of benefits for the heart, the kidneys. It is effective for heart failure. In fact, the cardiologists want to claim this medication as a cardiovascular drug. The nephrologists also want to claim it as a renal drug. It also has a potential benefit for fatty liver because of the weight loss. However, when your GFR goes down, you have less glucose-lowering efficacy, but it's still effective for protecting the heart and the kidneys. It is quite expensive, and we have to remember there is risk for diabetic ketoacidosis with this medication. You have genital mycotic infections because you're peeing out sugar. And one rare side effect possibly is fournier gangrene. So we need to be careful about this and really instruct the patient about perineal hygiene when they use this medication. They have to drink adequate amounts of water, and then when they urinate, they have to wipe the genital area so that they don't get infection. And fracture risk may be increased with these medicines. So how do we try to mitigate the diabetic ketoacidosis risk? You need to stop the medication 3 to 4 days before surgery, because they're usually NPO for that. Anytime there is critical illness or during prolonged fasting, we have to stop the medication. And we need to pay attention to the volume status. The blood pressure may go down with these medications about 3 to 5 points in general, based on the clinical trials. So we need to pay attention to the patients. Patients may have orthostatic hypotension, especially if they're starting out at very low blood pressures. Pero ito po talaga, mag-ingat po tayo sa fake news. Maraming produkto po na binebenta. Maraming produkto sa Facebook, sa internet, na nagbebenta ng kung ano-ano dyan, nagsasabi na cure po siya for diabetes, nakakababa po ng blood sugar, etc. Pwede nyo tanggalin yung mga gamot nyo, etc. Kailangan po tayong makinig sa ating mga doktor. Alamin po natin, sino ba nagsasabi niyang o nagpropromote niyang gamot na yan o ng supplement na yan or inumin na yan. Alright? Sana po trusted sources. So among the trusted sources po yung International Diabetes Federation, American Diabetes Association, World Health Organization, etc. Ano po ba ang katibayan ng mga supplement na yan? Totoo po ba yan? Tingnan po natin, suriin po natin maigi, saan po nanggagaling yung ebidensya? Galing po ba sa mga trial kung saan maraming tao ang gumamit at nakita talaga na patunayan na epektibo siya at ligtas siya? Kailangan po safe and effective. Yan. Okay. Yung nagmamarites po ba sa inyo, siya rin po ba nagbebenta niyan? Kasi baka naman ho, ang motivation po niya is more of profit rather than dahil magaling talaga yung binibenta niya sa inyo. So alamin po natin, tanungin po natin si Doc kung okay po ba yan, yung mga binibenta po sa inyo. Bago kayo bumili, bago po kayo magoyo o mabudol. So just remember the ABCs to prevent and treat diabetes complications. Hindi lang po blood sugar, no, or blood glucose. So we try to target A1C less than 6.5, but again, this has to be individualized. Pag medyo mas may edad na po, baka mas mataas na po yung target natin. Or kung marami pong comorbidities or mataas po yung risk for hypoglycemia, baka po mas mataas na rin po yung target natin. Blood pressure in general, less than 130/80. But again, that has to be individualized. And then yung LDL goal, depende rin po sa risk of cardiovascular disease. So, pag-uusapan niyo po ng doktor niyan, it could be less than 100 for the LDL or 70 or 55. Depende po sa risk niyo. So, yung mga na heart attack na or stroke, dapat po less than 55 yung LDL or yung bad cholesterol. HDL levels, 40 and above for men, and then above 50 for women. Triglycerides less than 150 in general. And wag po natin kalimutan yung ibang letters of the alphabet, D, E, F. D stands for diet, needs, dental smarts. They have to see the dentist every 6 months. Defender drugs, like the drugs I mentioned, pero mayroong mga other medications pa rin ho, like yung mga para sa cholesterol, mga gamot po for the blood pressure, etc. And of course, deal with depression because that can also increase risk for complications. E, screening po for the eyes and the kidneys. And F, screen the feet. Examine po the feet very, very well in patients with diabetes. Dapat po hindi sila nagpapaa. They should not be walking barefoot at all. So to summarize, multiple defects contribute to the pathophysiology of diabetes, leading to hyperglycemia. And to reduce complications for diabetes, patients need to be treated holistically. There are several classes of medicines that can be used to treat hyperglycemia, and early combination therapy is recommended to achieve the goals because there's so many defects in diabetes. These different medicines can target different defects. Newer glucose-lowering medications such as GLP-1 receptor agonists and SGLT2 inhibitors can provide benefits beyond glucose control like cardiorenal and weight loss benefits. And I always want to end with a positive note. Para sa mga bagets, baka hindi kayo makarelate, but this is the godmother of soul, Patti LaBelle. And she said, may diabetes po siya. She's 79 years old already. You can take hold of the situation. I feel great now. I live the right way. Everything I do now, I do it proud. I am a diabetic. So sana po nakatulong ako sa inyo na para yung mga pasyente nyo maging mga diva din. Mga diabetic din sila. Alright, marami na po tayong mga gamot ngayon para matulungan ang ating pasyente. Alright, and before I go, I'd like to invite everyone to the 30th NADE or National Assembly of Diabetes Educators. This will be on November 13 at the Makati Diamond Residences. So if you're interested, our theme is It Takes a Village to Empower Global Health in Diabetes. Just email diabetes.center@yahoo.com. So thank you very much for your attention.
Okay, thank you so much, Dr. Joy Fontanilla. I'm sure may mga katanungan po sa sa chat and also here in YouTube section po, and we encourage everyone to put in your questions in the comment section po of YouTube and Facebook. Very, very inspiring. Marami po akong natutunan for that even short, very, very short lang po na presentation ni Dr. Fontanilla. Okay, we'll go ahead po with our reaction. But before we proceed, we're seeing questions, but we encourage more and more questions po to be put in dito po sa ating Q&A box. Our reactor for today also another esteemed speaker po, an expert. For training po, Philippine General Hospital, Internal Medicine and Endocrinology, and did her postdoctoral work in Texas and in New York. She's now the chief of the Center for Diabetes, Thyroid, and Endocrine Disorders at the St. Luke's Medical Center. Please welcome Dr. Patricia Maningat.
Thank you so much. Thank you, Dr. Raymond, and of course, Dr. Dayon. And congratulations, Dr. Joy, for a very complete but simplified discussion. No? So I think it is very helpful that you gave the pros and cons of the different medications. No? Because, of course, when we hear about medicines, we usually just hear about the benefits. No, so just to give a very short reaction, so we have more time for questions. No? So again, Dr. Joy listed down all the newer medicines because for a long time, our main consideration for the management of diabetes was just sugar control. But now that we know more about the pathophysiology, we have new drugs, and we've discovered that we should really consider the other aspects of management of our patients. So we would want to know if the patients have cardiovascular cardiovascular, renal, or other metabolic risks so that we can choose the appropriate medicines. Of course, for the Philippines, one of the biggest consideration is also cost and the social support of the patient, because sometimes we do not want to just prescribe like a complex regimen that the patient cannot comply with. So it really takes a village to help our patients with diabetes. So our main goal again for the management is to control the blood sugars, but we want it without hypoglycemia, and our end point is to prevent the complications, both acute and chronic complications of diabetes. And then lastly, again, this is a holistic approach in the management of our patients. Glucose control is just one part, but again, we have to manage lipids, blood pressure, diet and weight, and the social support, including the diabetes support. Diabetes educators are also very important. So just to wrap things up, we need the right medicines, the right diet, monitoring, and follow-up to be able to successfully manage diabetes in our patients and maybe ourselves, if we also have these metabolic conditions. So that we can decrease the risk of diabetes and its complications later on. Yun lang naman, Doc Raymond and Doc Dayon. Thank you so much.
Okay, thank you so much, Dr. Trina. Then Dr. Dion will be moving on po very quickly just because in the interest of time, we wanted to get a whole lot more questions po from the Q&A. So we're looking here. We're looking here in the Q&A. I'll just shift.
I'll go
Go ahead,
first.
go ahead po.
Okay, so I think this is a very practical question, and maybe we have a lot of diabetics in the audience. They were asking about the ideal follow-up because Dr. Trina mentioned about not just the medications but also the monitoring. So anyone can answer actually. Ano raw po ba yung ideal follow-up and repeat lab check on patients on combination medications?
Joy, I'd like to go ahead.
Okay, so in general, we should be seeing our patients with diabetes quarterly, every 3 to 4 months. Okay, but depende talaga sa level of blood glucose nila. For example, if they're very high blood glucose and then you're starting insulin, syempre hindi mo nasasabihin na see you in 3 months. You have to see them more often initially. Pag medyo stable na, saka you can space out the follow-up already. So if you're initiating insulin, I tend to ask them to come back maybe in a week or so, just to make sure they're not getting hypoglycemia or finding out if they are having any problems with the injection techniques, etc. So depende talaga dun sa pasyente. But in general, every 3 to 4 months. If they're very, very stable, pwedeng yung every 6 months na.
Thank you. So, importante talaga yung individualized care, Dr. Joy, Although meron silang parang schedule na pre-prescribed like every 3 months or even every 6 months. Sometimes it has to be more closer monitoring as mentioned. And then sometimes if better na yung control, far apart like every 6 months or so. So, importante yung partner with your doctors and wag lang tayong susunod kay Marites na just, promoting this medication and then finish na, So, importante po, we partner with the doctors. Dr. Raymond, you have something there?
Thank you, Dr. Dion. Here, we have from Dr. Joseph Tortona, will genomics guide us in choosing the best anti-DM drug for patients as it is doing for anti-hypertensive drugs po?
Okay, genomics. Magandang topic din yan, pero another hour yun. So genomics, in many areas of medicine, we have nutrigenomics, with nutrition, we have pharmacogenomics. Yes, in the future, maybe, we'll use this as one of the tools to help individualize our therapy. But right now, we're not there yet. No, we're not at that point. It's still under a lot of investigation, but very exciting. And hopefully I'll see it in my lifetime, that we can use it to treat our patients.
Yeah, maybe just to add, there was the group of Dr. Pacheco and the NIH. No, they did some studies just looking really at the response of Filipinos to sulfonylureas and to metformin. But yeah, we're not yet at the point where we can use genomics to choose our medicines yet. No, yeah, hopefully in our lifetime, Joy, but we'll see.
Okay. Thank you,
Okay.
Ma'am Joy and Ma'am Trina. Can I ask one more question about insulin? We have several and we'll just put them together, no? So Ma'am A.V. Santiago was asking, is there such a thing as insulin plenty at Serpentina? Apparently it's effective in lowering the glucose. And for those on proper insulin medication, does it mean malapit ka na mamatay? Maybe our endocrinologists can clarify that.
Okay. Sige. Yung ano nga yung insulin ginagawang threat, no? Minsan sa pasyente. Sige, pag hindi ka kumain na tama, may insulin ka na. Actually, I always frame it for the patient. Huwag po kayong matakot or huwag po kayong mabahala na bakit ako nagre-reseta ng insulin. Isipin niyo na lang parang tangke ng gasolina yan no? Some of us are born with a full tank. All right? For example, some people are born with half a tank lang. All right? So iba-iba tangke yan. All right? So yung pancreas, yung insulin level natin pwedeng napakataas at the start. And then as diabetes progresses, sabi ko nga after 10 years, most people, more than half of patients with diabetes will need insulin. So wag po kayong mag-guilty o yung isipin na ay kasi hindi ako kumain ng tama, etc. Nauubos din talaga yung insulin with time. All right. And some of us have more insulin reserves in our body compared to others. So may iba, mas maaga po silang nangangailangan ng insulin. Pero hindi po isabihin nyo na malapit na kayo matay.
Okay.
Sometimes when we have patients who have newly diagnosed diabetes, they come in with sugars of 300 and 400. They're not type 1, no? And that high na level na glucose, toxic yun sa environment. No? So your pancreas is not able to respond appropriately. So there are times where temporarily you may need insulin just to get rid of that glucose toxicity, and then we can transition to oral medicine. So it really depends where you are in that spectrum of how much reserve you have. So if you've had diabetes for 20, 30 years, you're an old person, then you may need insulin start and then continue on. But for other people who are newly diagnosed, there is a chance that you can get off it. Now the insulin plant, yeah, so I think that's been asked also in previous mga webinars. Up to now, there's really no strong evidence to that. If that were true, siguro by now meron na talaga tayong guidelines on using. Of course, we would want if there is really a natural medication. But unfortunately, that hasn't been proven to effectively control diabetes.
Thank you.
So yung mga complementary medicines na ganyan, mga supplements, we ask our patients to be honest sana with us na what are they taking. Kasi meron, posible po magkaroon ng drug interactions with their other medications. Hindi lang po yung mga gamot for diabetes, but also for other medicines like yung blood pressure, etc. So, kailangan po natin malaman para malaman kung may mga interactions with that. And to check their liver and kidneys, baka kasi po may effects. Yes, these supplements may lower blood sugar, but we don't have those big studies to tell us na safe siya for the long term or effective talaga siya in which types of people with diabetes who will respond to it, etc. Pero maganda yung sinabi mo, Trins, na some people, they may start out with insulin, but once their glucose toxicity is resolved, they may be able to get off it. So when I start somebody, lalo na yung mga newly diagnosed on insulin, I give them that hope. Tingnan po natin, baka makarecover pa ho si pancreas nyo. And then eventually, mas-shift po natin kayo sa oral medications.
Very well said. Thank you, Ma'am Joy and Ma'am Trina. Doc Raymond, may question pa po kayo?
No, I think that should be it. The Dr. Dion, thank you so much to our endocrinologist po, Dr. Fontanel, Dr. Maningat. Thank you po for sharing your insights to our webinar. I see that there are some more questions, but we'll send them your way. Baka pwede pong masagot po kahit very quickly lang po. Maraming salamat. We'll be launching our evaluation poll lang po, no, as we are moving into the wrap up. Di pong evaluation poll po natin, we will not be sending a separate one. It's 5 questions, 4-point Likert scale. And we encourage everyone here to put in your feedback po. I know marami po kayo natutunan and we really want you to provide your feedback, not just on the topic but also on our speakers po. No? I'll read the questions as follows. The panelists demonstrated thorough knowledge of the topic. Number 2, the panelists were well prepared and organized. Number 3, the panelists spoke clearly and audibly. Number 4, the panelists and use appropriate language with technical medical jargons adequately explained. And finally, the panelists contributed to new perspectives and knowledge on managing various key health issues. So we encourage everyone to submit your feedback po. No? We will not be sending out a separate one. And then for next week, very exciting topic. Dr. Dion will share po kung ano po yung pag-uusapan natin on March 1st next week.
Yes, for next week, we will shift to malignancies, mga cancer po, and we have invited a very renowned surgical oncologist, Dr. Marco, to be our main presenter. So watch out for that. Next week po, kita ulit po tayo.
Thank you, Dr. Dion. But before we conclude our program, we want to make sure that all of you know that our webinars are archived po for viewing in the TVUP YouTube channel. So you just go to www.youtube.com/TVUPPH. You'll be able to see all 180 webinars. After today, 181 na po siya. At yung pong mga shorts po na tinatawag or selected presentations na very in snippet form po, no, we hope you'll be able to take the time out to watch all of them. They're just like 1 minute or so lang po ng mga videos po natin. I'd also like to take this opportunity to greet those who are watching us locally from the Cagayan Valley Medical Center in Tuguegarao, Cagayan, the Department of Education Regional Office in Legazpi City and Albay, Region 5, Cebu Veles General Hospital in Cebu City, Pasita Calizo Cortez Health Center in Balete, Aklan, Colegio San Agustin in Bacolod, Negros Occidental, and Zamboanga City Medical Center in Zamboanga del Sur. And internationally, you all know that we are being viewed, those from the Chonin Hospital in Taipei City in Taiwan, Lunichi Ali University of Blida II in Algeria, University Fail in Hail, Saudi Arabia, and Canadian Medical Center in Dammam, Saudi Arabia. So this formally closes po our webinar for this week. Makita-kita po tayo again next Friday from 12 noon to 1 p.m. It's a date.
Together, we can stop preventable deaths.
So keep safe, keep healthy, and see you online.